So cytoreductive nephrectomy, I think, is a very controversial issue right now in genitourinary oncology. The reason being is that cytoreductive nephrectomy the role of cytoreductive nephrectomy was initially established in the cytokine era. So this is an era where we didn't really have any effective systemic therapies for metastatic RCC. Now, from that time until now, we have very luckily had an avalanche of systemic therapies that have been approved and have improved outcomes for patients with metastatic RCC, namely targeted therapies. The advent of VEGF-R TKIs has really improved the outcomes of patients with metastatic RCC. And I think the question that has come with time is, as we have these more effective agents, systemic therapy agents, for the treatment of metastatic RCC, what is the role of this therapy in patients that present with upfront metastatic disease? Do we still need to remove the kidney out in these patients? So in the targeted therapy era, there was some very strong retrospective studies that tried to ask these questions. And what they found was that cytoreductive nephrectomy was still effective for the treatment of metastatic RCC, despite the fact that we had these novel systemic therapies at the time that were VEGF-R TKIs. But then the controversy came when the Carmina trial was published. The Carmina trial was a randomized controlled trial that asked the question, is sunitinib alone non-inferior to upfront cytoreductive nephrectomy plus sunitinib? What they found was that actually sunitinib alone was non-inferior. Now that is a randomized controlled trial, and a very large one at that, and a well-conducted one. But as with all trials, there are limitations to these studies. The limitation in Carmina is that the patients that were enrolled seem to be not the patients that would, in real-world practice, get a cytoreductive nephrectomy. Often these patients were higher risk disease. I think the rate of patients with IMDC poor risk disease was up to 45%. Patients had relatively high metastatic burden. Usually in practice, what would happen is patients that were, and this is more recently with the advent of VEGF-R TKIs, patients that would usually get referred to cytoreductive nephrectomy would be patients with low risk disease, patients that are more likely to become without any disease when we remove out the kidney. So the question that begs itself is that despite this randomized control trial that was negative, that showed that there was no role of cytoreductive nephrectomy, was there still a role in potentially patients that had more indolent disease, that patients that have better risk disease? And this is what actually one of the subgroup analyses of that clinical trial showed. So this was presented at last year's ASCO by Arnaud Mégeal, the head author of that paper. And what he showed is that patients with lower risk disease within that trial that had mostly poor risk disease or poorer risk disease, so patients with IMDC criteria 1 actually did well with cytoreductive nephrectomy. Now, this is a long introduction to actually say, what is our current question? The current question is that now we have even more effective systemic therapies. We have immune checkpoint inhibitors that are even better than targeted therapies. Is there now still a role for cytoreductive nephrectomy? The rationale being is that we went from very poorly effective therapies to more effective therapies, targeted therapies, now even more effective therapies. So this is the question that we try to ask in our data set, using the IMDC retrospective cohort, which is a consecutive cohort of more than 11,000 patients with metastatic RCC from more than 40 institutions across the world. We tried to ask, is there still a role for cytoreductive nephrectomy in patients treated with immune checkpoint inhibitor? Starting with those 11,000+ patients, we removed those that started with localized disease, we removed those with missing data and such. We restricted the analysis to after 2009 for it to be relevant to contemporaneous therapies. And then we had two groups: first-line targeted therapies, first-line immune checkpoint inhibitor-based therapies. What we found was that, first of all, the patients that were getting the cytoreductive nephrectomy are highly selected. So in practice, the patients that are likely to get cytoreductive nephrectomy, regardless if they end up getting a first-line targeted therapy or a first-line immune checkpoint inhibitor, are patients that are younger, are patients that have lower risk disease by IMDC criteria, and are patients that have generally a lower metastatic burden and don't frequently have things like brain metastases or bone metastases, etc. So after we address this, I think, important question of who is getting the cytoreductive nephrectomy, we then ask, is cytoreductive nephrectomy still associated with a survival benefit? Consistent with prior studies, we did find that in patients treated with targeted therapies was associated with a survival benefit. But what we also found that even with these more effective immune checkpoint inhibitors, we are still seeing a survival benefit with immune checkpoint inhibitors. Now, we tried to be very diligent in how we corrected for confounding factors. As we know, patients, as I just said, patients that are getting a cytoreductive nephrectomy are selected to do better. So the argument is, of course, you're going to see a survival benefit. So what we did is we did a multivariable analysis, but we also used a propensity score-based approach to be very diligent in correcting for confounding factors. And still, after doing all this, we did find a survival benefit in the immune checkpoint treated patients and in the target therapy treated patients. And very crucially, the extent of benefit that was seen in both immune checkpoint and target therapy treated patients seemed to be the same. So in conclusion, I think what our data suggests is, as we are still getting more effective therapies, and particularly here immune checkpoint inhibitor therapies, the benefit that we used to see in the target therapy era seems to be the same in the immune checkpoint era. Until we get more clinical trials and more data to inform management, I think the recommendations of which patients should be getting a cytoreductive nephrectomy should be the same as the one we had in the target therapy. Now, this is still controversial, but we think that patients with better risk disease, patients with lower metastatic burden, could still benefit from a cytoreductive nephrectomy, in particular if we can render them without evidence of disease, so NED. And I think I am personally eagerly waiting for the randomized controlled trials that are coming in this space. There's, for instance, the Nordic Sun trial that is being run mainly out of Europe, and that is asking the question, if we do upfront nivolumab, ipilimumab, and a deferred cytoreductive nephrectomy, is there a survival benefit? There's the PROBE trial that's looking at a host of immune checkpoint inhibitor-based regimens, the first line, and deferred cytoreductive nephrectomy. And there's the CytoShrink trial, which is looking at not cytoreductive nephrectomy, but SBRT to the primary kidney lesion in patients with metastatic disease. So again, getting at the question of, should we target the primary kidney lesion in patients with metastatic disease? So a similar question, although not with cytoreductive nephrectomy. I eagerly await the data from these trials, which I think are going to take quite some time. But in the meantime, I think the recommendations from the target therapy era should hold in the immune checkpoint inhibitor era.